Okay. So first of all, thank you to somebody. Somebody came up to me, and there's a typo on the vitamin K metabolism diagram where it says factors 2, 7, 9, and 10, except the 7 says 8. Well, obviously it's 2, 7, 9, and 10, and that's a typo. So I apologize for that, but just in case, you're studying and you get into this panic mode, like, oh my God, I could swear it was 7, but now it says 8, and there's no way Dr. Young could possibly make that stupid mistake. Well, I did. Anyway, so on that vitamin K metabolism one, it's 2, 7, 9, and 10. It actually has an 8, and I don't know if anybody's in here from ASSOR. They got to remind me to fix that for next time around. Okay, so now we're going to talk about hemophilia and von Willebrand disease. And rare bleeding disorders. At the end, just a brief thing on rare bleeding disorders. So I'm going to give you just some interesting hemophilia history, just as some background. These won't be on the test, but I think they're interesting tidbits, I think, to know, and I think they illustrate some of the points I'll make later anyway. So first of all, hemophilia was first noted in the 2nd century, one of the oldest diseases we know, because it was mentioned in the Talmud, which is a book of Jewish rabbinical teachings, and it says, quoted, if she circumcised her first son and he died, and a second one also died, she must not circumcise the third son. So in Judaism, of course, circumcision is part of the ritual of the religion, but you got an excuse if your first 2 sons died. So God is compassionate, maybe not that compassionate, but he's definitely compassionate. And then it was recognized actually also in the Talmud in the 12th century by a physician and religious scholar named Moses Maimonides, and he noted it was X-linked because he said, and I won't read the whole quote, but see what's there in red, whether the latter child was from her first husband or her second husband. So you immediately see 2 things there. One is he noted that it was X-linked, and 2 is that Judaism does not have a prohibition to divorce, unlike Catholicism, one of the big differences. But that won't be on the boards either, not these boards. And then the first description of factor 9 deficiency is really interesting. If you look at the title, it says Christmas disease. It has nothing to do with Christmas. The boy's name was Stephen Christmas. And then underneath it says a condition previously mistaken for hemophilia. This is really kind of funny. That was from the 1950s. And the most famous person with hemophilia is the son of the last Tsar of Russia, Alexei Romanov. Pictures of him here, flexed knee due to bleeding, bruising, and being wheeled around in a wheelchair or in a sled chair. Snows a lot in Russia. And that was all descended from Queen Victoria. And Queen Victoria was a carrier of hemophilia. And not too long ago, a couple years ago, they actually found the body of Alexei Romanov because he was killed during the Bolshevik Revolution. It's another interesting part of the story. But they found his body, exhumed it, got some DNA out, and turned out he had factor 9 deficiency. All this time they thought he had the more common form of hemophilia, factor 8 deficiency. So let's jump into the facts that you need to know. So hemophilia is the term used to describe deficiencies of factors 8 and 9, also known as hemophilia A and B. And deficiencies of factor 8 and 9 are inherited in an X-linked recessive pattern, which I'm sure you know. Heterozygous females, i.e. carriers, can be symptomatic. In the past, we use the term symptomatic carriers. It's not really a very good term because if they're really low, we just say they have mild hemophilia or sometimes even moderate hemophilia. But in women, usually they are heterozygous. It's rare. There's a handful of cases of true homozygous hemophilia in women in the United States. Another situation where you can get sort of a real full-blown hemophilia, it's really unusual, but in a girl with Turner syndrome, she only has one X chromosome, and if that one has the gene, then she'll have, hemizygous hemophilia, but it'll be similar in nature to homozygous hemophilia. I don't think they'll ask you about Turner syndrome, but you do need to know that it's an X-linked recessive pattern, because often the questions will be, a 4-year-old comes in with blah, 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 and, he has 2 uncles and a grandfather, and they give you this bleeding history, and they're telling you, I'm telling you about an X-linked disease, so you immediately need to start thinking hemophilia if they start giving you a family history of brothers, uncles, and grandfathers. Molecular basis of hemophilia, they want you to know this. So about half the mutations are in intron 22 inversion. It's a very kind of strange mutation. I won't show you the picture of it for time's sake, but it's an interesting type of mutation where the intron 22 is inverted and leads to abnormal transcription. Almost the other 50% are specific point mutations. and I'll show them to you in a second. Mild and moderate hemophilia is almost all point mutations, so it kind of looks like this. Severe factor VIII deficiency, this is just from one study, but it's roughly 40 to 50% is the intron 22 inversion, and then a litany of different types of mutations from missense, so one amino acid mutation, right, which could be missense, it could lead to a frame shift, it could be a nonsense mutation, or rarely in hemophilia A, you have large deletions. So I think you just need to know that intron 22 inversion is the most common. In moderate or mild hemophilia, it's almost all missense mutations, and in mild, it's practically all missense mutations. So that's the difference. Intron 22 inversion in severe is the most common, missense mutations in moderate or mild. Hemophilia B is a little bit different, where small and large deletions are more common, and they tend to be associated with severe hemophilia B, and missense mutations, again, dominate mild and moderate. So here, you don't have intron 22 inversion, right, because it's obviously a different gene. You have missense mutations occupying about half, and then large and small deletions occupy a bit of a chunk of the rest of it. And nonsense mutations are important, too, because they lead to full dysfunction of the protein. Moderate and mild is going to be pretty much all missense mutations. Okay, they want you to know the clinical and laboratory manifestations. So this is a table that you do need to spend some time on. I don't think you need to spend too much time on the molecular defects, but this you need to know because they will ask you scenarios and vignettes that will relate directly to this. So first of all, obviously you must know the difference between severe, moderate, and mild. Less than 1, 1 to 5, and 5 to 40. And the typical age of presentation, I have an asterisk there because the age of presentation is pretty highly variable, especially with moderate and mild, but those are kind of roughly when we tend to see them, and I think if in a board question format, that's kind of what they're aiming for. If they give you kind of an infant, probably they're going for severe hemophilia. If they give you a school-age child, it's probably going to be more likely moderate hemophilia. If they give you an older child, it'll probably be more likely mild hemophilia, just as a general approach. And the presentation, well, family history, obviously, 70% of the patients will have a family history, and so you can diagnose it in pre or more likely immediate postnatal screening. Otherwise, if that's not done, in neonates, we'll often get bleeding from circumcision or heel sticks. And I am continuously amazed at how often this is missed in the community. I just got a call to help in like a medical legal case where a kid was bleeding from a circumcision for like a week, and they stitched him, they sent him to urology. They did everything possible except check a PTT, which would have made the diagnosis. So it's incredible how often this is still missed. If you don't have those, then in severe, you'll get bruising in less than a year. You can get vaccine-related bleeding, mucosal bleeding, joint bleeding. In moderates, neonatal bleeding is less common. We don't tend to see it in neonatal. That's why we usually diagnose it more in that toddler age. Once they start like really moving around and falling, then all of a sudden you start seeing these minor trauma-related bleeds, which are pretty common. The classical thing in moderate is a frenulum bleed or a mouth bleed. The kid's like toddling around, he fell, he bit his lip, and then it won't stop bleeding. That might be a scenario that you'll get from moderate hemophilia. Mild hemophilia, they'll probably give you like a major post-trauma event, or more likely like a post-surgical event, and somebody kept bleeding. Inhibitors, which we'll talk about later, the highest risk, obviously, is, maybe it's not obvious, but is in severe hemophilia and usually factor VIII deficiency. We don't see a lot of inhibitors in factor IX deficiency. And the risk for hemophilic arthropathy, so the joints are what gets damaged in hemophilia, it is universal in patients with severe hemophilia unless they're treated with prophylaxis. It's very common in moderate hemophilia, but rare in mild hemophilia. Another thing they want you to know is typical bleeding locations, by locations and age. So we already talked about circumcision, and I mentioned heel sticks. And basically, line for line through the rest of this table is the lines match up. So as the arrow is showing you, from one line, just go straight across the other line. So post-circumcision heel sticks are really common in severe hemophilia. I mean, that's why the Talmud figured that out 1,800 years ago. But apparently some pediatricians can't figure that out in the 21st century. Sorry, I tend to be cynical sometimes, more than sometimes. 4 weeks to 1 year, typical type of bleeding will be you start to see bruising as they start to cruise around. Post-vaccination bleeding, we can see that. And towards the end of that first year, you can start to see joint bleeding. Intracranial bleeding, thankfully, as you can see here, is rare, 1% or less, but it can happen. And so again, as you look at these, just draw your attention, go straight across, and that's the site and then the frequency. These are all, again, line by line. That's why there's a gap here, because muscle bleeding took a couple of lines there. So I won't keep reading all of this. This is for you to read mostly at home. So when you say unusual bruising, like, well, all kids bruise, Dr. Young. What do you mean unusual bruising? Well, like that, or like that, or like that, or like that. This thing felt like a steak. I mean, literally, you could feel you could put your hand around it like a piece of meat. So I always have my phone around to take pictures. Or post-vaccination bleeding and joint bleeding and muscle bleeding. This is from an MRI. You can see a triceps hematoma on these two sides. And mucous membrane bleeding. So this kid bit his tongue, right? And you think, well, it'll bleed and it'll stop. Well, it just kind of kept bleeding. And so this illustrates also that that a clot is very, very important for proper wound healing. So he never made a good clot, and so he didn't get proper wound healing. And this thing stayed there. We actually ended up having to put this kid on, I think he had moderate hemophilia. He ended up going on factor, I'm not exaggerating, for 3 months until this thing actually went away. You can imagine how this would just keep rebleeding. I mean, every time he put a potato chip in his mouth, it would start to bleed. So, post-traumatic bleeding. This baby was affectionately known as Mono Mickey, if you think about that for a second. He got better, and he's totally fine. But this kid fell off his bicycle, and you can see right here is that's the handlebar, right there, and did some damage. He ended up being fine too. This was a teenager, and he told us nothing happened until we said, well, you got this big giant intestinal hematoma. The intestine should look like this little fine pink color. So this big giant, they thought it was going to actually rupture. That's what it looks like on CT scan. And we finally said, are you sure you didn't get punched in the stomach? And he looked at me and said, how did you know that? And I said, well, I guessed. No, I mean, he was punched in the stomach and ended up having this massive hematoma. And intracranial bleeding, thankfully, it doesn't happen very often, but it does happen. Retroperitoneal hemorrhage. So they want you to know, they specifically mention in the content outlines, retroperitoneal hemorrhage. They say this. So you will likely get some sort of question about this. And again, this may be in combination with the other things we talked about earlier, with the age and the PT, PTT. So when they ask the questions, they're asking you to put all these sort of knowledge-based facts together. So this is a common type of internal hemorrhage, usually resulting from bleeding in the iliopsoas muscle. The symptoms would be pain in the flank, so side or back, or in the groin, or sometimes they say in the thigh, which is referred pain. And the pain is exacerbated and localized by right lower quadrant to the right lower quadrant, and also by extending the leg. So if we're not sure somebody has one, we do one of those, the same test they do for appendicitis. You just dangle the leg off the side of the bed, and they won't let you do that. Or more typically, I can tell a patient with an iliopsoas bleed as they're walking into the clinic, because they walk like this. If you can't see me, they walk like hunched over, like this. And you already know they have an iliopsoas bleed. You don't even need to do any other testing. And that's because walking hunched over keeps the iliopsoas muscle in the relaxed position and not in the stretched position. So it can look like this. This is the psoas portion of the iliopsoas muscle. That's the normal one. That's the big fat one. And blood leaked out into the retroperitoneum in that area there. Or it could be in the iliacus portion. There's the normal iliacus muscle. There's the psoas. They kind of come together in the lower abdomen, and then there's a circle there, which is a bleed in the iliacus muscle. Diagnosis, so screening assays. The PTT is almost always prolonged. For the sake of the board exam, it's always prolonged. Okay, in reality, it's not always. There are some unusual mutations in mild hemophilia that give you a normal PTT, and you have to test them with a different type of factor VIII assay that you don't need to know about for the boards, and you can ask me about later. So if you have a prolonged PTT, you then just do a factor assay. I mean, I always tell people that hemophilia is really, really easy to diagnose. Prolonged PTT, you just measure a factor level. The only hard part is to think of it. is to put in your differential diagnosis. Once you've thought about it, the rest is easy. You just send a blue top tube to the lab, say do a PTT. If it's abnormal, do a factor 8 and 9. Or if you already have a family history and you know it's 8 or 9, you could just do one of those. And then genotyping can be done to determine the molecular defect, as I showed you earlier. You can do prenatal diagnosis. They want you to know, can you do it? You can, if you get fetal DNA from these different ways. And testing is easiest if the genetic defect in the family is already known. Now, factor levels are not reliable enough for prenatal testing. Remember that factor 9 is physiologically low in neonates. It's even lower in fetuses. And factor 8 can be falsely elevated. So you should never, ever rely on a factor level in prenatal testing, especially to make decisions. I mean, why do you do prenatal testing? Basically, if you're going to abort the fetus or not. So you should never rely on factor levels to make those decisions. Carrier testing. So heterozygous women can be symptomatic due to lionization or non-random X inactivation. And their factor levels would tend to fall in the mild hemophilia range. 10%, 12%, 20%. We've got lots of moms in our practice that we follow who we've diagnosed with mild hemophilia as a result of being carriers. Now, it can be diagnosed with factor levels, but you also have to rule out von Willebrand disease, which we'll talk about next, because the treatment's going to be slightly different. And certainly, von Willebrand disease is common enough that you know how to make sure which diagnosis you have. The most reliable way to diagnose carriers, though, is through genotyping, because a normal factor 8 level does not rule out being a carrier. I've had moms come to me and say, hey, my doctor told me my factor 8 level is 80%. How can I possibly have a son with hemophilia? Well, factor 8 levels can go up, as you heard earlier, lots of different reasons. Inflammation, birth control pills make them go up. So factor level by itself is not a good way to make 100% sure somebody is or is not a carrier of hemophilia. Treatment. General approach is either on demand, we use the word on demand, but basically it's episodic as needed. When you bleed, you treat. When you don't bleed, you don't treat. Versus prophylaxis, which is exactly what it says, prevention of bleeding. We use these 3 medications to treat hemophilia. We'll talk about each one of them. Factor replacement, desmopressin, we already briefly mentioned earlier. Antifibrinolytic therapy, we already talked about. And then special situation surgery. And for some reason, they throw in dental procedures and hematuria. I don't know why they picked hematuria and not bleeding from some other orifice, but they chose hematuria. So we'll mention those. This is a complicated diagram, but let me walk you through it. This is different ways of treating hemophilia. So this is the age from 0 to adulthood. This is episodic treatment, where each line represents, sort of in a cartoon fashion, giving a dose of factor. So episodic treatment is a treatment of pain and treatment when you have pain and serious bleeding. You can do something called short-term prophylaxis. So somebody's had a target joint. We'll talk about that in a second. You want to give factor for some length of time, a few weeks, a few months. You can do that. That can help, again, especially with something called target joints. Tertiary prophylaxis, somebody already has joint disease. All right, their knees or elbows or ankles, they're already messed up. But by doing this level of prophylaxis, you can improve normal activities of daily life because they won't bleed as much. Secondary prophylaxis is, here it says after the second joint bleed. It's basically starting prophylaxis after some number of joint bleeds, but before the onset of joint disease. And in this case, you'll have minimal musculoskeletal damage. Wherever there was bleeding, that may be damage, and you may not be able to fix that, but you can prevent other damage. And primary prophylaxis is really before the second joint bleed, and there you can have totally, it says near normal, but really have normal musculoskeletal and psychosocial development. One thing you'll notice, though, is that the amount of factor required for all of these increases dramatically as you go downwards, as the arrow shows you, from episodic to primary prophylaxis. And I always need to throw this in there, obviously won't be in the exam, but just be aware that 80% of the hemophilia patients in the world don't get any factor, and it's kind of a sad, unfortunate thing. So prophylaxis implies the regular administration of factor replacement therapy in order to prevent bleeding and its complications. I already mentioned primary prophylaxis and secondary prophylaxis, and those are the differences, and they may ask something about that because they wanted you to know the differences between those. Indications. Well, it doesn't differ whether you have factor 8 or factor 9 deficiency, and it's generally used in severe hemophilia to prevent hemophilic arthropathy. Again, in the U.S., we should start it before the second joint bleed. Usually we start it after one joint bleed, and sometimes even before the onset of joint bleeds. Moderate hemophilia patients who bleed frequently should also be on prophylaxis. Dosing, I don't know how much dosing they get into, but I'll give you a few things that you do need to know, and I'll highlight those as I'm speaking. So this is like general dosing for prophylaxis. I don't think they're going to ask you that. You just need to know that it means regular, frequent infusions, 3 times a week, every other day. I don't think you need to worry about the number. I put the number there for your reference. Same with factor IX, except factor IX has a longer half-life, so it's twice a week. Now, you may have heard of new longer-acting factor therapies. They will not be on this board exam. So you don't need to worry about those. Even if your clinic is using them, you're like, wait, Dr. Young, he didn't say anything about that extended half-life 8 or 9. And you don't need to know about that. It won't be on the boards. You can ask me later if you're interested. So on-demand episodic therapy, this is appropriate for mild and most moderate hemophilia patients. It means you treat bleeding when it happens. It doesn't prevent bleeds. And in the severe hemophilia situation, it won't prevent joint disease. But most patients with mild hemophilia don't bleed that often, and so they're much less likely to ever develop joint disease. And so for them, intermittent, on-demand, episodic, those different words, therapy is appropriate. They want you to know how to treat chronic arthropathy. I don't know why, but they want you to know that. And chronic arthropathy can develop even after one joint bleed. One bad joint bleed, especially if it wasn't treated right away, can lead to the development of arthropathy or joint disease. And then multiple bleeds in the same joint are referred to as a target joint. And a target joint actually has a strict definition, 3 bleeds in 6 months or 4 in a year. The management of chronic arthropathy, they want you to know that. The goals are to improve joint mobility, reduce pain, and to try to achieve optimal functions for activities of daily living. I don't know exactly how that's framed in a question, but they wanted you to know that. I guess what they want you to know is the different types of intervention: medical, so initiation of secondary prophylaxis; surgical, which can be fixing the inflamed joint, and usually that means a synovectomy or removing the synovium, which is inflamed and leads to a lot of the bleeding. It doesn't mean, somebody asked me, well, what happens if you remove the whole synovium? It's not removing the whole synovium. You're removing all that excess tissue that you get from synovial hypertrophy. The intact synovium lining stays. The other would be pain management, physical therapy, and assistive devices as needed. Okay, this is, again, there's no clinical trial data to support this, and I don't think you need to know all this in too much detail, other than intracranial hemorrhage you should correct to 100%, and joint bleeding usually correct to about 50%. I think those 2 things are worth knowing. And surgery, correct to 100% as well. So how do you do this correction? And I'm sorry, there's a typo down here at the bottom of the factor IX, but it's not something that's that important. So I think this part you do need to know. So this is about dosing. This is what you need to know. So if you combine, I'm going back one slide. If you combine the knowledge in these 3 red boxes, 100% correction for intracranial hemorrhage or surgery, roughly 50% correction for a joint bleed and a muscle bleed, if you will. If you know that, and then you add this slide, then, if they ask you about how to treat a joint bleed, you'll know. So factor VIII, basically 1 unit per kilo increases your factor level 2%. So if I go back a slide, you can do the math. For a joint bleed, 25 units per kilo of factor VIII will get you to 50%. 50 units per kilo will get you to 100%. And they may give you a slide with all kinds of wacky numbers, but just hone in on like 25 or 50 is probably where the answer will be. For factor IX, 1 unit per kilo increases you 1%. And I think there's a recombinant factor IX called Benefix where the recovery is lower. That's that second dash line under the bullet. Don't worry about that. I even have a typo where I didn't complete it for the other recombinant factor IX. I think for the test's sake, 1 unit per kilo of factor IX increases you 1%. So if we go back again to here, basically you need double the amount of factor IX to get to the same point. So you do need to know, again, these boxes here and the factor VIII, those 2 middle ones, 1 unit per kilo increases you 2%, factor IX, 1 unit per kilo increases you 1%. You know those 2 bits, you'll be able to answer whatever questions they throw at you as to how much factor IX or factor VIII is needed to correct, to treat a bleeding scenario that they might give you, or a surgical scenario. Okay, moving on from factor, there's desmopressin. We mentioned earlier that it increases factor VIII, most likely by increasing circulating von Willebrand factor. So they might try to trick you, and they'll have a patient with factor IX deficiency, and they'll give you choices for treatment, and desmopressin might be in there. That would be the wrong answer. Right, desmopressin does not work for factor IX deficiency. And it's effective for mild hemophilia A. usually for minor things like mucocutaneous bleeding, minor dental procedures, and there are some mild mutations that are not responsive, but don't worry, they're not going to ask you that. They just want you to know that you can use desmopressin to treat mild hemophilia A, not B. Also, patients less than 3, because it's an analog of antidiuretic hormone, may get fluid overload and potentially could have seizures. It's pretty much a moot point because patients with mild hemophilia are rarely diagnosed before the age of 3 unless there's a family history. They want you to know the pros and cons of factor therapy. Well, the pros are you get immediate, rapid, and reliable rise in factor level. Right? You're missing factor 8. What's the best treatment? Give factor 8. It works. And the half-life is long enough that you get sustained levels for at least 6 to 12 hours. And it's highly effective, and it's safe except for that risk for developing inhibitors. We'll talk about that in a bit. The cons, the downside is it's intravenous. So it's, you have to find a vein or you have to have a central venous catheter. It's not available everywhere in the world. It is available everywhere in the U.S. It's very expensive. Annual cost to treat a hemophilia child with prophylaxis is about $300,000 to $400,000 a year. Inhibitor development is a huge con because 30% of the patients, roughly, I said 25% before, it's about 25 to 35% overall will develop an inhibitor. If you just remember a quarter or a third, that's good enough. Pros and cons of desmopressin. Well, the advantage here is it's intranasal. So when we use it at home, we give patients an actual nasal spray. It can be given IV or sub-Q too, but there's really no need because the absorption is great from the nose. It's effective for mild bleeds. It's basically safe. Some patients get flushing and they don't like it, so you may not be able to use it in all the patients, but that's a minor side effect. And relative to factor, it's inexpensive, though, mind you, this little tiny bottle costs about $600. The cons are that the levels don't really peak sufficiently high for a really serious bleed. So we generally don't use it for joint muscle and definitely not for intracranial bleeding. And because the levels go up in relation to a rise in von Willebrand factor, they drop down very quickly. So within 4 hours, usually you're back to baseline. So for some nasty hematoma or some mucocutaneous bleeding, it's very useful, or for some minor procedures. They want you to know pros and cons of factor 9 therapy is basically the same as factor 8, except that the inhibitor rate is much less. It says here about 5%, which is what's generally quoted, though it's probably closer to 1 to 2%. Surgical management. They want you to know how to manage surgery. So I already mentioned you want to correct to 100%. So first you want to make sure the patient doesn't have an inhibitor. You want to correct them to 100%. And then you keep repeating the bolus doses to maintain a trough of 50%. I don't think they're going to ask you about how often you give doses after because it's not that clear. But they will ask you, how much factor do you give if somebody's going to have a major surgery or surgery in hemophilia. And that relates back to the other slides I showed you earlier. You can use continuous infusion, but they won't really ask you that. And then antifibrinolytic drugs can be added. So they may give you a scenario where they'll have a patient having dental surgery or dental work or TNA, right? They'll already tell you they gave factor. And then they'll say, in addition to factor, which of the following would be an effective therapy? And that's where they might throw like a factor 9 patient in there, and they'll throw desmopressin and try to get you to answer that. Whereas the answer probably be Amicar. So we kind of went over this already. Forget the continuous infusion. You don't need to know that. 50 units per kilo gets you to 100%. Here, again, 100 units per kilo is good enough to remember. It'll get you to 100%, right? 1-to-1 for factor 9. It says, so then they gave me these 3 scenarios, or give you guys really these scenarios. How do you manage like dental extractions or dental surgery? Well, dental extractions are a pretty nasty kind of surgery, even though it doesn't seem that way. So you want to correct to about 100% and adding an antifibrinolytic agent. So they're probably looking for a combination. If they're asking you a question about dental, they're probably looking for factor and antifibrinolytic agent. Pressure and desmopressin is really not fully reliable in this setting. I don't know why they want you to know how to manage hematuria. I'm not even sure I know how to manage hematuria, and I've been doing hemophilia for like 20 years because it's really difficult. But they want you to know, I guess, correcting the factor level, and in this case, hydration is important. I think that's the other piece that's important with hematuria is hydration. This they definitely want you to know, that antifibrinolytic agents are contraindicated. I think for the board exam, they're contraindicated. In reality, if you know the bleeding is from the bladder, I've had patients where I got consulted to help with hemorrhagic cystitis. You can use Amicar if it's that low because the urethra is wide enough that if any clots form, the clots will pass through. But the ureters are way too narrow for that. So the reason why it's contraindicated is you get clots that form, these tenacious clots that can get stuck in the ureter. And I actually tried to use Amicar in a couple of really bad situations with renal bleeding, and I got burned both times, so I've never done it again. So that it's a real true contraindication. So that one's not an alternative fact. That is the truth. So I think if they're going to throw a question on hematuria, they want you to know not to give antifibrinolytic agents and to rely on factor replacement and hydration. We give steroids. I don't know really why. I'll tell you why, because there's a paper from like 1968 where they gave like 5 patients steroids, and now we rely on that as if it's the gospel. I don't think they'll ask you about steroids. Okay, this is really important because it says you must know what are the reasons for therapeutic failure of factor replacement therapy. Signs would be lack of response to treatment of a bleed. So they'll give you a scenario that they gave factor and the kid's still bleeding. Or they'll give you a scenario where somebody's on prophylaxis, but he's having a lot of bleeds. Breakthrough bleeding, we call that. Or excessive bleeding during surgery or post-operatively, even though you gave factor. The causes could be insufficient factor dose, so you might look at, so again, that's why you need to know a little bit about the dosing, or more likely they're going after is the development of an inhibitor. So you must test for an inhibitor right away, and if there's bleeding, you treat with a bypassing agent. We'll explain what that is shortly. And for patients on prophylaxis, if you think they developed an inhibitor, you just, at least for the moment, you stop giving the prophylaxis. So now we talk about inhibitors. An inhibitor is the term for a neutralizing antibody. So it's an antibody developed against the factor protein, either 8 or 9, that renders the factor replacement either less effective or ineffective. Inhibitors significantly complicate the management of hemophilia. Really, these are the patients that still today suffer a lot. The bleeds are more difficult to treat because while we have treatments that I'll show you in a minute, they're not nearly as effective as replacing the missing protein. If you replace the missing protein, you correct coagulation to normal. If you can't do that, these other bypassing agents help generate thrombin, they help make a clot, but it's not as good. So these are risk factors for inhibitor development. I think they do want you to know that, and I think you can look at this a bit later, but they want you to know the inhibitor. So one of them is genetic. I'm going to get to another slide where I give you some of the pearls. The only thing to know about the inhibitor rate with genetic stuff is large deletions cause more inhibitors. I mean, all the rest of this is kind of jumbled together. The missense may be a little less, but most of the mutations don't give you an increase or decrease risk except for large deletions. So this is really the main pearls. If they're going to try to get you to diagnose an inhibitor, they might tell you that there's a family history of inhibitors. Identical twins have almost 100% concordance. So one has an inhibitor, the other will get an inhibitor. Siblings have a high concordance, but it's not 100%, it's about 70%. And then uncles or grandfathers is even less than that, it's barely above background. With inhibitors, severity of hemophilia matters. Severe, by far, most of the inhibitor patients are severe. Very few patients with moderate and mild hemophilia ever get an inhibitor. And for the molecular defect, as I mentioned just before, large deletions are the most likely to give an inhibitor, followed by nonsense mutations. And then importantly, race. People of African race have African Americans in this country have a higher incidence of inhibitors than Caucasians. So how do you diagnose it? It's a test called the Bethesda assay. And this looks really complicated. I don't think you need to know all the detail, but I'll walk you through it quickly. I don't think I'm going to ask you too much about like the mechanisms of this test. So there's 2 forms, the classical and the Nijmegen modification. They're basically, you'll see, they're very similar. You don't need to know the difference for the boards. So you take the patient's plasma and you mix it with normal pooled plasma. In the Nijmegen, it happens to be buffered, but you mix it with normal pooled plasma. And that results in what we call the patient 1-to-1 mixture. The patient's plasma, 50%, mixed with normal plasma, like the mixing study we showed earlier. In the case of the Bethesda assay, you then also do a control mixture where you take the buffered normal pool plasma and mix it with a buffer. The normal pool plasma, mix it with a buffer, or the buffered normal pool plasma and mix it with the factor VIII deficient plasma. The bottom line is you end up with 2 mixtures. You end up with the patient mixture and the control mixture. The control mixture, you know how much factor VIII should be in there. It should be basically 50%. And then you have the patient mixture, which is the unknown. And then you measure the factor VIII activity in the mixtures. And you end up with a ratio of patient factor VIII activity divided by the control factor VIII activity, which is what's called the corrected residual activity. So if a patient does not have an inhibitor, those numbers should be exactly the same. The ratio would be 1. If the patient has an inhibitor, right, then when you mix the plasma, they should have less factor VIII in here. There'll be less factor VIII in here than in here. And so this ratio becomes less than 1. Less factor VIII in the patient, more, and we know the control is 50%. And then the conversion is basically an inverse square. It's a weird math thing, but it's an inverse square. So in other words, if you have half, in other words, if in the factor VIII, if in the patient mixture there's 25% factor VIII, we know the control mixture is 50%, and that's half, then the inverse square is like 4, and that gives you a Bethesda assay of 4. This is the graph that gets plotted. And so if you have 50% residual factor, that by definition is called a Bethesda titer of 1. And if, for example, it's 25%, it's 2, and sort of so on. And, the machine generates these curves and give you the numbers. I think mostly you just need to know that the Bethesda assay is a test used to measure inhibitors, and the higher the number, the stronger the inhibitor. There are things called transient inhibitors. They want you to know that. As the name implies, it's only transient. It's clinically insignificant. It's only found in routine surveillance. And you just keep treating the same way you were treating before. There are 2 types of inhibitors, a high titer and a low titer. And it's broken down by the Bethesda titer of 5. Above 5 is high, below 5 is low. And those who are above 5 are always going to be above 5 unless they don't get any factor VIII exposure. They may drop below 5 because you haven't given them any antigen. But as soon as you give them antigen, it's going to shoot way up again. And that's called a rapid anamnestic response, right? Not amnestic, not amnesia, anamnestic, remembering that they have this inhibitor. And so they're called high responders. In other words, they're always going to be high. Okay? Anybody who's greater than 5 is always going to be high. There are patients with low titers that are low responders. In other words, they stay low. Even when you give them factor VIII, it doesn't shoot up. It's kind of a weird immunological phenomenon. And these ones, the difference is they can be treated with factor just at a higher dose. So what you need to know here with the high and the low is if you have a high factor VIII inhibitor, you cannot treat with factor. You cannot treat with regular factor. If you have a low titer inhibitor, that's a low responder, they may not even throw low responder. They might just say low titer. You can treat with factor VIII. I'll come back to that. So management of inhibitor patients, we try to eradicate the inhibitor via immune tolerance therapy, and then bleed management, either treating or preventing. Immune tolerance means the regular daily infusions of factor VIII, rarely factor IX, to quote-unquote educate the immune system to become tolerant to the factor replacement therapy. And the treatment takes a long time, and it's very labor-intensive. And I don't think you need to know the details of like when tolerance is achieved. We still sometimes argue about that amongst ourselves anyway. But essentially, if they give you a scenario where the Bethesda titer is 0, you can just assume that the patient has achieved immune tolerance. I'm giving you this sort of information as sort of a little more information for your own knowledge. Regimens are in the U.S. we usually do daily because with daily you get fewer bleeds. You can do every other day. So bleed management. This is the part I thought this might be a bit important. Low titer, low responder inhibitor. On the exam, they might just say low titer. They may not get into this low responder thing. So if it says low titer, you just use factor VIII replacement therapy. You just need to give more. And there's a rough formula. It's not really validated, but you can take the units you want to give. So let's say you want to give corrected joint bleed, 25 units per kilo, and you multiply it by the titer. Remember, the titer is always less than 5 in low titer. So if the titer is 3, in a sense, you can give 75 units per kilo, and that should be enough to overcome the inhibitor. And then you have to recheck the inhibitor, make sure that it hasn't gone up and that they're not a high responder. Okay, how do we manage bleeding in high titer inhibitor patients? All of them are high responders, as I said. So this one where you can't use factor VIII. They may give you a question and they'll give you all kinds of factor VIII. Give 100 per kilo, give 50 per kilo, give 20 per kilo. If they tell you it's a high titer inhibitor patient, those answers are wrong. You cannot give factor VIII. You must use what are called bypassing agents. There's only 2. One is called anti-inhibitor coagulant complex, although we generally call them activated prothrombin complex concentrates, or APCCs, and there's only one of those on the market, and recombinant factor 7A, and there's only one of those on the market. So we don't have a lot of options. I'm not going to read through all this. I don't think they're going to ask too much about this kind of stuff, but this is the difference between the two. I mean, they want you to know the bypassing agents, so I gave you the properties here of the two different bypassing agents, and you can read that on your own. So the main points of inhibitor management is know that you can treat low-titer inhibitors, especially low-titer, low-responder, with regular factor. Know that you cannot treat high-titer patients with factor replacement, so you have to use the bypassing agents. Know that desmopressin is ineffective in inhibitor patients. Okay, moving on to von Willebrand disease. It's the most common bleeding disorder, 1% by lab testing, although probably only 1 in 500 are real cases. People actually have bleeding. Symptoms are mostly mucocutaneous bleeding, except type 3 von Willebrand disease, where you can have bleeding like hemophilia. So typical bleeding is epistaxis, easy bruising, oral bleeding, post-surgical bleeding, and menorrhagia in particular, in obviously females of childbearing age. So von Willebrand factor has two functions. Really important to know this because this is where the testing comes out. Platelet binding function and carrier of factor VIII. So it is the carrier for factor VIII, and it binds to platelets. And VWF, we already mentioned, is increased in stress. Also DDAVP, of course, estrogen, pregnancy, and is an acute RASE reactant. So here's another one of my cartoons. Von Willebrand factor is that the sort of coiled line. It unfurls. We already sort of looked at this earlier, so we'll go through this quickly. Captures the platelets. Platelet adhesion, the platelets get activated, and then leads to platelet aggregation. So von Willebrand disease is divided into several subtypes, and this you have to know. Type 1 is autosomal dominant, heterozygous defect with reduced production of a normal von Willebrand factor molecule. So the molecule is normal, we just make less. It is a partial quantitative defect. Type 2A, autosomal dominant. This is one of the qualitative. The type 2s are all qualitative defects. In this case, there's a multimerization defect, so you're missing the large and intermediate size multimers, which are the most adhesive, the most sticky. Type 2B is a gain of function mutation, where von Willebrand factor is too adherent to the platelets. It's so adherent to the platelets that the large multimers stick to the circulating platelets, and so they're not really available to function when bleeding occurs. Type 2M is the opposite of 2B. It's a loss of function mutation where von Willebrand factor doesn't bind well to the platelets. Type 2N, so remember platelets, von Willebrand factor has a factor VIII binding function. Remember I mentioned that, right? So 2N is the loss of that function where von Willebrand factor does not bind to factor VIII. And you'll need to know these subtypes. Type 3 is a quantitative, it's a total quantitative defect. Type 1 partial quantitative defect, type 3 total quantitative defect. And you need to know this because this relates to the testing, which I'm going to show you shortly. So there's no good screening test. So forget PTT doesn't really help. Yeah, the PTT might be abnormal, factor VIII is low enough, but they're not sufficiently sensitive. So we do diagnostic tests, which include the von Willebrand factor antigen. It's an immunologic test that tells you if von Willebrand factor is present. It doesn't tell you anything about the function, it tells you if it's there. We have to measure the two functions of von Willebrand factor. The platelet binding function in an assay called the ristocetin cofactor activity assay. In some labs now it's just called von Willebrand factor activity, but it's basically all based on the same principle of ristocetin, an old-style antibiotic that's not used anymore, which basically bridges the von Willebrand factor to the platelets and assesses the platelet binding function of von Willebrand factor. And then we measure the factor VIII activity. It's exactly the same test you do for hemophilia. In this case, you're measuring the factor VIII binding function of von Willebrand factor. And then we'll do a multimer analysis to look at the different sizes. So von Willebrand factor multimerizes. It's got small, medium, and large. You can think of it that way, just like T-shirts, except in the big and tall shop. And so I'll show you the gel in a second that looks at a von Willebrand factor multimer analysis. So here's a table for diagnosing the different subtypes of von Willebrand disease, and you just need to know this. So I'll point out a few things. So type 1, everything is a little bit low, except factor VIII could be normal. Multimers are present, all sizes. Type 3, you have nothing. So that's easy. They'll say everything is missing. So type 2A, what's the key to diagnosing it is the multimers. Decreased large and intermediate molecular weight multimers. Because as you see, the factor VIII, VWF, and risk-seeking cofactor can all be really quite the same as type 1. Type 2B, this is the one that is the gain-of-function mutation. So we take advantage of that when we test. And we do a test called the RIPA, which stands for the ristocetin-induced platelet agglutination. And it's similar to the risk-seeking cofactor assay, except you're using the patient's plasma and normal platelets. And in this case, whereas the platelet aggregation is the patient's platelets, basically what you're looking for is to see excess binding of von Willebrand factor to platelets, which is what the defect is. Remember, that's what the defect is. So if you put a little bit of ristocetin, normal people, it will not bind. The von Willebrand factor will not bind to the platelets with a small amount of ristocetin. But if you have type 2B von Willebrand disease, it will. And that's the test that will diagnose type 2B. 2M, you just get a ratio difference. The risk-seeking cofactor should be much lower than the von Willebrand factor antigen, which actually could be normal. In 2N, you have a very low factor VIII, so it can be confused with hemophilia, and oftentimes, if they were trying to tease this out of you, they'll give you a family history where this is autosomal dominant or at least not X-linked. So what the gel looks like, there's normal. There's type 1. You can see all the multimers there, although they're kind of faded out a bit. There's type 3, there's nothing there. And there's 2A, where you're missing the intermediate and large molecular multimers, and in type 2B, you're missing the large multimers. I don't know that they'll show you a gel, but they might. You need to know the influence of blood type. So type O has the lowest levels of von Willebrand factor. I think that's the most important thing to know. A, B, and AB are kind of close together. O is low. Just remember that for von Willebrand factor. Treatment options, okay, we already talked about desmopressin, and we can also use a replacement with a plasma-derived von Willebrand factor concentrate. And we already talked about antifibrinolytics, which are very good for this disease. And hormonal therapy is particularly effective for menorrhagia management, and so they may give you scenarios where you may need to use one or any of these. And topical therapy can also be used, although I don't think they'll question you about that. So it's a super busy table, but good one for you guys to look at and try to remember some of the details. I'll just point out a few things. So it's treatment by the type of von Willebrand disease and the bleeding situation. Type 1, we use DDAVP and antifibrinolytics. Mostly that's what we use. Desmopressin at home, Amicar or Listetta, the antifibrinolytic agents at home. If you have menorrhagia, we throw in the hormonal therapy as a possible treatment. 2A is pretty much the same, except DAVP really shouldn't work, although some people try it. For minor surgery, you can go with DDAVP in type 1 and antifibrinolytics. But for major surgery, always we use von Willebrand factor replacement and antifibrinolytics if appropriate. 2B, 2N, 2M, and 3 is very easy. We have to use von Willebrand factor replacement. If there's menorrhagia, we use hormonal therapy. So you see a lot of these boxes sort of repeat. Okay, finally, rare bleeding disorders, just a few points. They don't ask you to know too much, but a little bit. So these are the factors that can be deficient in rare bleeding disorders, and you need to know a few unique features about them. In fibrinogen, so if you have afibrinogenemia, splenic rupture is not that uncommon. I have a patient that had that. I mean, on this board exam, I guess maybe Hodgkin's disease can give you splenic rupture too, but if they're going after a bleeding situation and they say splenic rupture, it's afibrinogenemia. Factor 2 and 5 are so rare, these deficiencies, I can't imagine they'll ask you a question about it. Factor 7 is very similar to hemophilia. Factor 10, intracranial hemorrhage, is a bit more common. Factor 11 is more common in Ashkenazi Jews, but they don't tend to bleed a lot. Patients generally with factor 11 deficiency. Factor 13, we talked about the umbilical stump bleeding, and also that they have the highest prevalence for causing intracranial hemorrhage. So those are a few sort of nuggets about these factor deficiencies. So they're rare. We call them rare bleeding disorders because they're rare. And they're all, well, except in Ashkenazi Jews where factor 11 deficiency is quite common. The inheritance pattern is easy. They're all autosomal recessive. The treatment is variable. I don't think they're going to ask you too much about treatment. You heard in the blood transfusion lecture yesterday that cryoprecipitate has fibrinogen. factor 8, von Willebrand factor, and factor 13. Well, we've had concentrates for factor 8 and von Willebrand factor for a long time, but fibrinogen concentrates and factor 13 concentrates are relatively new. So if you're in a situation where it's an umbilical stump bleeding and they give you choices for treatment and factor 13 is not available, it's not one of your choices, then the correct answer is cryoprecipitate. Same thing for low fibrinogen. If they give you a situation with bleeding and splenic rupture and what's the best treatment, and your options do not include a fibrinogen concentrate, the answer is cryoprecipitate. For the rest, there are generally replacement factors. Dysfibrinogenemia, they want you to know about this. It's a rare inherited disorder due to a dysfunctional fibrinogen, and that can cause bleeding or thrombosis. It can cause bleeding if the dysfibrinogen leads to poor clot formation, or it can lead to thrombosis if the dysfibrinogen makes a good clot, but it's then resistant to fibrinolysis. They want you to know the lab findings, so this is where the thrombin time comes in. And treatment for bleeding, you replace the fibrinogen, and for thrombosis, it's anticoagulation. So I know I'm kind of out of time. I think, is that the last slide? Yeah. So that's it, and I will stop there. And actually, just a minute or two over. Sorry, is there a break now? Where's Cindy? Is she back there? Is there well, you guys can tell me. Right, there's a break, isn't there? Yeah. Whew, thank God, I need a break after that. So I'm happy to answer some questions. Otherwise, take a break and come back at 3:55. Thank you.